Thanks everyone for joining us today to learn more about how to successfully integrate tobacco cessation treatment into behavioral health care. I'm Kelly McEnany. I'm a senior staff attorney working in the commercial tobacco program at the Public Health Law Center. I'm thrilled to serve as moderator for this wonderful presentation. And we actually have a great mix of folks signed up and registered to listen to this presentation. So as Steph mentioned, please feel free to put questions and thoughts into the Q&A box. We will save time at the end for that conversation. Okay, so before I introduce our two wonderful speakers, I'm first just going to spend a couple minutes telling you a little bit about the Public Health Law Center. And I realize that some of you on the call have heard many of these presentations, and these slides are burned onto your eyeballs. So please feel free to grab a cup of coffee or take a stretch while I cover this information. The Public Health Law Center is based in St. Paul, Minnesota, and we would like to recognize that our physical campus is located within the traditional homelands of the Dakota people in an area known as the Bdote region. We appreciate the ongoing stewardship, spiritual connections, and life ways developed in these homelands upon which the law school sits. The Public Health Law Center works to reduce and eliminate the use of commercial tobacco, promote healthy food, support physical activity, and also tackle climate change. And we actually have a new-ish program that aims to strengthen the public health infrastructure throughout the country. And here's a slide that gives you a quick snapshot of the work that we do. We provide legal technical assistance to public health professionals, attorneys, advocates, community members throughout the country. And this legal TA includes help with legal research, policy development. We provide litigation support, such as filing amicus or friend of the court briefs in high impact cases. We maintain a litigation tracker on our website that summarizes and provides updates on key cases that are affecting the public health community. We provide webinars like the one today. We develop publications and trainings, and actually for this audience, we recently did a webinar and a publication on increasing access to cessation treatment and medication by expanding the scope prescription authority of pharmacists. So we hope you'll check that out. I also want to note, make a quick note about terminology, that when we're using the word tobacco at the Public Health Law Center in conversations like this, we're talking about tobacco products that are industrial scale, commercial tobacco products, but not traditional tobacco, which has been used religiously, medicinally, and ceremonially by many indigenous communities and tribal nations since time immemorial. And if you want to learn more about this, we encourage you to do so, and you can check out this website link on the slide. And we do want to remind everyone and ourselves that health equity is at the center of our work. And when we're crafting policies and thinking about public health work, we remember that people are differently situated, and applying the same policy across the board may have different effects and outcomes for different groups of people. And this other slide helps us understand what those external factors might be. This is a graphic talking about the social determinants of health. Of course, there are also the political and legal determinants. This helps explain why some people are healthier than others, and it also helps explain why the leading causes of poor health and death in the United States are largely preventable chronic diseases. And I know our speakers are going to talk more about some of the very concerning disparities in use rates among certain populations, so I won't get into that now. But we do want to acknowledge that equity very much is at the core of support for cessation services and treatment. Okay, and now for the main event. It's my pleasure to introduce our two fantastic speakers for this webinar. First, we'll hear from Reba Mathern-Jacobson, who leads the American Lung Association's behavioral health efforts in Minnesota and North Dakota. She coordinates the Lung Mind Alliance, which involves statewide partners implementing strategies to reduce the disparities and impact commercial tobacco use has on people with mental illness and/or substance use disorders. She has over 20 years of experience living and working within behavioral health settings and doing program development and policy. And our second speaker is Dr. Kavita Prasad. Dr. Prasad is a board-certified physician in general internal medicine. She qualified from the University of London, trained at the National Institutes of Health and Mayo Clinic. Dr. Prasad is currently the medical director of integrative medicine for Zumbro Valley Health Center. She's passionate about the underserved population and providing equality in healthcare, and has published on integrative therapies to improve well-being. Before we hear from Dr. Prasad, I'm going to turn it over to Reba to kick us off. Reba?
I hope that you can see my slides now.
Yes, we can see your slides.
I want to start out and just say that, yes, I am an employee of the American Lung Association, and our mission is to improve lives by improving lung health. And so I'm very happy to be in this position where the whole focus is how can we work together as folks who are involved in public health, partner with folks in mental health and substance use disorder fields to recognize we have a common concern that folks with these conditions smoke at a higher rate than the general population and suffer the consequences at disparately high rates. And so the Lung Mind Alliance in Minnesota is the place where those organizations come together to address that disparity. Just echo what Public Health Law Center says, that when we're talking about tobacco, we are referring specifically to commercial tobacco. I just want to start out with a few slides to show a little bit about how this disparity came about, that folks with mental illness or substance use disorders use tobacco at higher rates than the general population. A lot of that is due to targeting of these populations by the tobacco industry, that they have made money and fortunes by promoting the idea that smoking is a way to improve your disposition, to help you feel better, to help you manage anxiety, to manage your nerves. So those are a few just historical ads to show that. But of course, there's been targeting in other ways, such as free cigarettes given out in psychiatric institutions, given out in the military, given out at the VA, and many other instances. So where does that put us then in looking at the smoking rates in this population? This graph shows the blue line are folks that have a mental health or a substance use disorder, and the red line is showing the smoking rate among people without those conditions. So you can see that those adults are smoking at higher rates, but we are looking at how to narrow and reduce that gap. So with this data in 2013, you're looking at about a 15, 16 point gap. And with this latest data from 2023, we're down to about an 11 point gap. But that's what we are trying to eliminate. Again, here's some reasons for why that disparity exists. I do want to point out that this is the only aspect of healthcare delivery that it is not the norm to have a smoke-free facility, that those facilities were exempt since 1993. So how does this play out? What does this look like? We know that tobacco is the #1 cause of death in people with these conditions. So more than, complications from alcohol or opioid overdose or suicide, that these folks die more often from tobacco than any reasons or things associated with their mental health or addiction. We also know that 75% of this population is genuinely interested in tobacco recovery. So they want to quit smoking at the same rate or a higher rate than the general population. That's generally misunderstood. And we also know that if somebody is in treatment for a substance use disorder, that if they can concurrently get help into tobacco recovery, that they have a 25% greater chance of long-term abstinence or sobriety. And so really, that's one key factor that really points out the benefit of providing tobacco treatment to this population. Just another point there, that this population buys more cigarettes than the general population. And then in this next slide, I'm also showing you then that this is a meta-analysis that shows that when people get help with tobacco recovery, their mental health really improves. So this shows that anxiety goes down, depression goes down, stress is down. And then opposite of that, of course, then is that their feelings of well-being and their perception of their quality of life really goes up. This is a piece from the NIH and SAMHSA that says some of those same things. I just like to point this out, that this is the standard perspective of SAMHSA and national leaders, that really this is the best place to be providing tobacco treatment to folks is in the places where they're receiving mental health and substance use services. This is a glimpse of a toolkit from SAMHSA. Again, just stating that their recommendation is that substance treatment programs adopt a tobacco-free grounds policy and integrate tobacco treatment into the other services that they're providing. I want to point out that ASAM, the American Society of Addiction Medicine, has a consistent message with that, and they're also advising that treatment organizations screen all patients, offer evidence-based treatments, and have a tobacco-free grounds policy. So now that the research is starting to show up in practice, where are we at? So I'm going to show you a few slides now that look at Minnesota data, but compare it to national data. So if you're not from Minnesota, this will still be relevant to you. So we have here the dark blue bar is for Minnesota mental health facilities, and the light blue bar is for the US rate of mental health facilities across the country. And we can see then that we have, 70% of organizations are screening for tobacco use in the population when they're coming in for services. But when we look at, if folks get a positive screen, to what degree are organizations providing the appropriate treatment? Less are providing counseling, even less than are providing the medication of gum patches and lozenges for nicotine replacement therapy. And then even fewer are offering the other medications such as varenicline. And we know from the research that varenicline is currently showing to be the most effective treatment in helping people to reduce or eliminate their tobacco use. So as we look at the efficacy of these treatments, we're not utilizing them to the degree that we could be and should be. And then when we look at the smoke-free campuses, we're looking at only half of facilities have smoke-free or tobacco-free grounds. The red line is showing where we were in 2016 compared to the full blue bar, which is 2024. So as we look at this, you can see that there is great improvement with room to grow. So this is Minnesota and US mental health. Now this slide is referring to substance use treatment facilities. You can see that the general trend is the same in terms of more assessment happening than treatment happening. And then this slide here is just Minnesota data, and comparing in one slide the substance use facilities in the light blue to the mental health facilities in the dark blue. And you can get this data for your own state. But really it just shows that same trend, that we're not offering treatment to the degree that we could be. And it's not always consistently just the mental health facilities are doing more than the substance use facilities. It kind of depends on what aspect you're looking at. So to get the the research and the evidence base into practice, we're really looking at culture change, needing to do a lot of staff education to help folks who are professionals in the mental health and the substance use arena recognize that they really are the best ones to be providing tobacco treatment to folks, whereas it has traditionally been left in the primary care arena. People are coming to mental health and SUD treatment, and so it's a perfect time to offer those kinds of therapies. And mental health and substance use professionals generally have a longer ongoing relationship with their clients or patients than primary care, which makes it another reason why it's a good place to provide that kind of treatment. So at the Lung Mind Alliance, we do a lot of work to try to gear up the professionals to really take it on as their responsibility to provide this kind of treatment and support, and to build their confidence in integrating that into the care that they provide. So these are a few examples of some of the resources that we've developed at the Lung Mind Alliance. We have these first 3 one-pagers that are designed for professionals, kind of exploring some of the myths and facts about providing treatment in those settings. And then we also have this tips from the field guide that was written by Minnesota professionals that gives some guidance for how to make organizational change in their own site. We have developed some client education materials. The Love Your Pet one is really popular, but it's a way to engage clients in the conversation. A lot of people have pets. They love and adore their pets, and of course, they are also vulnerable to the harms of cigarette smoke in the place where they're living. We also have access for free to this curriculum called Learning About Healthy Living, Tobacco and You. This was written by Dr. Jill Williams, who's an addiction psychiatrist and a national expert on the intersection with tobacco use. This is a curriculum that can be used for individual or group-based treatment. So you can find that at our website, lungmindalliance.org. And then we also do things such as we provide technical assistance in a few different formats. Sometimes we work with organizations one-on-one, helping them to rewrite policy or just to do staff surveys, assess where are opportunities within their organization that the tobacco piece can get some attention. And sometimes we offer our technical assistance in a cohort model where a group of 3 to 5 organizations will meet together on a monthly basis with a stipend to help offset their staff time for participation and give them some technical assistance. And one aspect of that is having a mentor participate from an organization that has already done a great job at thorough integration of tobacco treatment and support into their services. So having that mentor from an organization with a lot of experience to provide that support to new organizations that are newer to that work. So that's just a little bit about the cohort that we have. And then I'll just leave it at that. You can find resources, like I said, at lungmindalliance.org. Also wanted to just make a mention that the National Council for Mental Wellbeing has a tobacco section. They have monthly office hours where folks can call in and ask questions and get support that way. And then the Smoking Cessation Leadership Center at UCFS has a lot of webinars for folks who are interested in more information on this topic and how they can be providing tobacco treatment in their centers. So thank you very much.
Thank you, Reba and Kelly, for that kind introduction and for the lead up to my section of the talk. I'm delighted to be here and to share some of the work that we've been doing at our facility at Zumbro Valley Health Center, which is based in Rochester, Minnesota. So just bear with me with the technical skills here. The main focus of my talk will be two parts: how we integrated tobacco cessation into our health clinic and the reason why we did that, the rationale behind why we did that, and the model that we have developed, a holistic approach to health to really treat the whole person and deal with the underlying stress, which so often is the reason why people are smoking. Now, this work, you can probably gather from my accent, I grew up in London, in England, and from a very young age, I was out on the streets serving food, helping at a soup kitchen, seeing a sector of society that was not availing health services that were freely available. And when I look at, in hindsight, at the work I'm doing now, the pieces of the puzzle match up so perfectly. I was lucky to train at the NIH, Mayo Clinic, and then give back the skills and techniques I've learned to serve this population, which had pulled at my heartstrings at a very young age. So here I will talk a little bit. Reba has already mentioned the importance of tobacco treatment in mental health facilities. And as I came to work in this organization, my prior work was not in psychiatry at all. My background is in general internal medicine, and my fellowship was in integrative medicine. So that holistic approach to health was there. So when I came to Zumbro Valley Health Center in 2019, when this job opportunity opened, I was reading up a lot about tobacco and mental health and cardiovascular health. And I was surprised to find that cardiovascular disease, while it's the leading cause of death worldwide, it is the leading cause of death in our patients with mental health conditions. And tobacco use was the number one preventable thing that we could focus on to reduce that cardiovascular risk and that premature mortality that we were seeing. We know that, from our previous talk by Reba, that mental health and substance use recovery are improved if people are given access to tobacco cessation facilities and patients are wanting these techniques and learn how to quit use. I'll talk a little bit about how we set up our services and this holistic approach to tobacco cessation that we have been working on. So Zumbro Valley Health Center is based in southeast Minnesota in Olmsted County, and our clinic really focuses on this integrated collaborative approach to health and wellness services with a person-centered integrative approach. So while we are based in Olmsted and Fillmore counties with 3 locations in Olmsted County, we serve the surrounding counties too. And our roadmap, we serve the publicly insured and the uninsured populations with mental health, substance use, and we recruit a diverse workforce that meets the needs of our clients. We provide timely access to care and deliver care really centered on the client that improves health outcomes and reduces health disparities. We work in partnership and outreach with different organizations to provide that best possible care. Our facility is a non-for-profit developed in 1966, and it's not until 2020, 2021 when we started talking about tobacco cessation here. It's one of the safety net clinics in town and was one of the first community certified behavioral health clinics in Minnesota when I joined. And I know these numbers have, CCBHCs as we call them, have increased throughout the country. We had 2 locations when I joined and 4 currently, just highlighting that increase in mental health and substance use that is increased throughout the United States and in many countries across the world. As our locations have expanded, so have our staff numbers and our client numbers. Mental health care, as you may know, was previously very fragmented with long wait lists. And our patients get in to see a provider very quickly. So once they call in for an appointment or are referred, we develop, access to care right away. With one assessment, one care team is developed for that patient, and we have one treatment plan. So everyone works very collaboratively at our facility, and very compassionately too. The services we offer are for both youth and adults, and we are based in the school systems as well, with school-based mental health services. We have substance use and recovery services, and a whole building has been opened just for recovery services for our adult population, highlighting that increased need. We have supportive services, so our staff go into into the homes of patients to help them if they are requiring one-on-one help with their groceries, with their medications, just with life skills. There's peer support, there's homeless outreach. We have a crisis and a detox unit, which is over 20 beds, where patients who are found on the streets or are requiring detox are brought in by law enforcement and can stay up to 3 days. And then we have a 90-day residential treatment unit where patients can stay up to 90 days to learn more intensive skills to improve their mental health. And I work in the outpatient integrated clinic along with our psychiatry providers. Our clinic aligns with the county's priorities. For the last few years, they've remained the same: improving mental health, drug use, and the timely access to care. Now, what is really surprising in this population, and 40% of all cigarettes smoked in the United States are in those people with a mental health condition, behavioral health conditions. And suicide and mental health drug use is not the leading cause of death in our population. It is heart disease. And heart disease, as I mentioned, is preventable if we can reduce and eliminate tobacco use in this population. Lung cancer is the leading cause of cancer. We know it's linked to tobacco use and lung disease too. Severe mental health illness are classified as those psychotic disorders: schizophrenia, schizoaffective disorder, bipolar disorder, and major depression. And about 5 to 10% of the population in the US has a diagnosis of a severe mental health illness. And this population dies on average 15 to 25 years younger than an average adult. So we have the opportunity to really prevent premature death caused by cardiovascular disease in our patients with mental health problems. This slide is adapted from the 2023 National Survey on Drug Use and Health. And you can see from that small pie that about 64 million people are using tobacco products in the last month. And on the bar graph to the right, you can see these are mainly with nicotine vaping or with cigarettes. Now, when we look here at this slide, we can see that severe mental illness is in red. The blue-green bar is in those with any mental health illness, and the gray bar is in those without a mental illness diagnosis. You can see illicit drug use, marijuana use, opioid, alcohol use, and the use of tobacco products is much higher in those with mental health illnesses. Schizophrenia, bipolar disorder, and cardiovascular disease. A large meta-analysis of over 3 million people with schizophrenia was carried out, and it was found that people with schizophrenia have a higher incidence of coronary artery disease, strokes, heart failure, and cardiovascular disease relative to the general population. And people with bipolar disorder, there's about 7 million Americans with bipolar disorder, and cardiovascular disease is the leading cause of death in this population too. People with depression, 1 in 5 people, 20% of us will develop depression sometime during our life. People with depression have a higher prevalence of smoking, and people who have depression consume more cigarettes daily and are less likely to quit too. showing you this graph. This was published in the Journal of the American College of Cardiology in 2022. As more is being talked about the link between the brain and the heart, we're seeing that on the first set of bars under smoking, you can see the general population is in purple. The patients with schizophrenia are in light blue. People with bipolar disorder are in red, and people with depression are in the black. So just looking at the tab under smoking, you can see the higher percentage of people with mental health problems using cigarettes, using nicotine products. You can also see on this graph that metabolic syndrome, obesity, dyslipidemia, and hypertension, diabetes are higher in this population. Many times patients seen in behavioral health clinics are put on antipsychotic medication, and a side effect of that medication is increasing blood sugar levels, causing abnormal lipid profiles, and obesity, as well as metabolic syndrome. So there's a huge opportunity in behavioral health clinics to make a difference and improve healthcare. So barriers do exist, challenges exist, but we have the opportunity to improve cardiovascular health. There's in the underserved population, which is the population I am seeing, there's low health literacy sometimes, there's social determinants of health, poor self-care. There aren't health providers in these facilities who are aware of these risk factors, and there's really a disparity in healthcare between those with in the poverty, lower socioeconomic status. So this just really highlights that again. We've talked about it, severe mental health illness, cardiovascular risk factors, and health problems are there, but tobacco cessation can help in all of these to reduce the risk, the excess risk from cardiovascular mortality and severe mental health illness. So gathering this information, we decided, when I joined in 2019, we decided, how do we really help this population improve their cardiovascular health? Because we're knowing that these severe mental health illnesses and patients with these diagnoses don't receive guideline-based treatments for cardiovascular disease prevention. So we are focusing on cardiovascular disease prevention and reducing mortality from cardiovascular disease. Now, many times when I see patients, they say, "Doctor, I can't stop smoking. It's my stress. I'm using it for managing my stress." And really, we've tried to focus on and hear from our patients and provide evidence-based treatments at our facility. So once we gathered the information, I reached out to the Lung Mind Alliance and to Mayo Clinic. The Lung Mind Alliance and Reba specifically provided our staff with a survey to understand what staff knowledge was on tobacco treatment. And out of the staff members that responded, 2/3 of them felt that people should have access to tobacco treatment services, and that was consistent with the mission of our facility. But there were 1/3 that weren't sure or didn't agree with that. The topics that staff wanted training on were tobacco use and mental health, tobacco treatment and recovery, and how tobacco treatment relates to other substance use. And so we reached out to Mayo Clinic's Nicotine Dependence Center, who very kindly provided 3 lunchtime lectures for all of our staff on tobacco use, mental health, substance use disorders, youth nicotine use, and how should our staff communicate on tobacco cessation if staff members wanted to talk more about tobacco cessation, how should they kind of do that? Mayo Clinic also offered our staff members, 6 of our staff members were trained free of cost through scholarships, and we embedded these tobacco treatment specialists in different areas of our clinic. So in our detox unit, in our inpatient unit, in our psychotherapy unit. So there were 6 tobacco treatment specialists as champions in each of these areas. And we created an email just for those staff members, started a monthly journal club where we would discuss the latest evidence-based research. We were provided carbon monoxide monitors so patients could blow into a straw, see what amount of carbon monoxide was in their lungs, really educate the patients. We did filming with the Lung Mind Alliance to inform other behavioral health clinics on the importance of tobacco cessation, on improving mental health and recovery from substance use. We testified in the tobacco legislative session to obtain reimbursement for other staff who were providing tobacco cessation services. We started a youth program for tobacco cessation, but we found that youth were not presenting for tobacco cessation. They were using tobacco as a method of coping with the stress they were facing. We implemented from the American Heart Association, the ASCVD risk estimator, your 10-year risk of developing a cardiovascular disease based on your smoking status and your cholesterol profile. And we also started an integrative medicine metabolic psychiatry clinic to deal with these unmet healthcare needs. So our clinic now offers metabolic syndrome evaluation for each patient. It has we have health and wellness coaching, a mindful eating program. We collaborate with public health and Mayo clinics to be part of the Park RX program in nature therapy. We take our patients to the food bank for healthy food choices. And we have brought in different stress management techniques because if we can focus on the root cause of this stress and help patients with that, then we can improve their well-being. So we have brought in biofeedback with the Heart Math program, where a sensor is applied to the patient's ear or to their finger. They can see their stress levels on the computer screen, and then they can learn different techniques, including yoga, Tai Chi, stress management techniques, to really reduce that stress and see how it feels without turning to nicotine, for example. We've brought in Reiki, which is a Japanese form of healing, a very ancient form of healing. This is free of cost. It helps on relaxing the mind and the body. We've brought in the mantra repetition program and meditation. And in 2025, we published 3 articles in collaboration. Our first one was with Harvard and Mayo Clinic. We surveyed our patients on their use of complementary and integrative medicine. And we found that among about 100 patients that we did survey, patients were using other modalities for managing their symptoms, including prayer, spirituality, and music, to improve their mood, their stress. And many of our patients reported social isolation and loneliness. And just looking at that a little bit further, the impact of the complementary therapies helped reduce pain, which is so important in this population, helped improve their mood, reduce stress and loneliness. And we listened to the patient and brought in the mantra repetition program, a portable mindfulness technique that also incorporates spirituality. We published on our work with Reiki, along with the University of Toronto, Mayo Clinic, and the University of Arizona. And in our patients that received a Reiki session, we found that patients' pain reduced, anxiety and stress were reducing, and they were feeling happier, calmer, more relaxed. And if you can see here on this graph, I know some of the writing is a little small, but on the top graph here, we can see that the blue bar is for males, the orange bar is prior to a Reiki session, the orange bar is after a Reiki session, the gray bar is for females prior to a Reiki session, and the yellow bar is for females after a Reiki session. We can see that pain, fatigue, anxiety, stress, sadness, agitation, all of these reduced after a 1-hour session of Reiki. In the bottom graph here, we looked at happiness, energized levels, relaxation, and feeling calm. After the Reiki session, all patients felt more energized, relaxed, and calm. We found that women felt happier after a Reiki session. Men didn't feel happier, but their happiness didn't reduce. The Global Flourishing Study was published just last week in the Nature journal. And just to share with you the greater, this is a large study that's looking at global flourishing as an index of well-being. And it's from 22 countries in the US and outside, a large patient sample. Greater frequency of religious attendance is associated with fewer cigarettes smoked per day in a dose response effect. And this was a step, you can see the US really demonstrated this in a positive way. The mantra repetition program that I've mentioned before is a spiritual tool that we have brought in and piloted in our recovery programs. People, a small group of our patients that took part in this program recently in an 8-week program, found that their stress levels reduced, they were feeling happier, and their cravings for substance use and nicotine was reduced with this program. This is an evidence-based program. We also found behavior changes and published on that this year. A patient, this is a single case report using this program, but cholesterol levels and blood sugars reduced at 4 months after the Mantram program and was sustained at 9 months. Now, we have a great opportunity to innovate in mental health care, I believe, at this time. We're not the first to be doing this. The VA has already, across the country, introduced this holistic model of healthcare. In mental health care, we have an opportunity to reduce cardiovascular risk by focusing on a biopsychosocial spiritual model of care. We've recently been offering in the school system at the Alternative Learning Center, which is a school that sees students with behavioral health conditions, mental health conditions, and nicotine use. We are collaborating with them and offering a 5-week program of a holistic wellness approach rather than talking about tobacco cessation or substance use. We're talking about a well-being program, and students seem to be finding benefit. We're collaborating with many organizations across the country and across the world at this time. And there is my contact details if you have any further questions. We rely on support to develop our programs, and a QR code is available for anyone who is interested. Thank you, everyone, for your time.
Thank you so much, Dr. Prasad. It's a wealth of information you shared, and thanks to Reba as well. I think we're going to try to squeeze in one question, and I know we've had some great ones come through, and we can follow up separately with those folks we did not get to. But I'm wondering, this is a question for both of you. If you want to share your thoughts, can you say more about how to make the integration of tobacco treatment more appealing among mental health providers through their systems of care, and looking for ways to finding points of integration between public health scopes of work and the established systems of care for direct providers? I sense that could be an entire presentation in addition to this one, so maybe just some quick parting thoughts about ways to get started, if you don't mind.
Well, I think somehow tobacco has gotten a pass, like it got put into its own separate category, like it's not a drug, but it is a drug. A drug is a drug is a drug. And so if you just think of, these systems, they know how to treat every other kind of addiction. And they can just apply those same principles to tobacco. They don't need to specialize in tobacco. They don't need to have a whole new tobacco track. They just can weave tobacco conversations into the work that they're already doing. Dr. Prasad?
Yeah, I agree with you, Reba. I mean, I think there's a huge opportunity to work together to improve the integration of tobacco cessation better, using the model that you say and the models that we have developed here. These are all low-cost models or no-cost models of care. It's really just learning from each other and working in unity to kind of just say, this works really well at our organization. Let's just educate more of our staff working at these behavioral health clinics, because as I am going out speaking to to different organizations, different areas within our clinic, we have, mental health clinics have a high staff turnover. So and many of the providers working there are not traditionally healthcare professionals coming as recent graduates and so on. So if we can go out and educate behavioral health providers on the importance of tobacco cessation and develop a model, maybe a policy to how to do this, we can really have a huge impact with public health and with behavioral health clinics and policy with the public health law.
Well, that's a perfect note to end on. Well said. And thanks to both of you for sharing this wonderful information and this wonderful case study. And it sort of speaks for itself. So the more we can amplify the results of this and the innovative strategies that were so successful, I think we'll get at some of what that question was asking. So thanks to both of you. Thanks to all of you for joining us today and participating. And please do take a minute to fill out that survey, the post-webinar survey. And yes, the slides will be available. So please be sure to check out and some of the resources that were discussed today as well. So thanks again and have a wonderful day.
Thank you. Take care.
Thank you.